Good evening, everybody, and thank you so much for joining us here at the BJSS office in Leeds and online on Zoom. Just a quick introduction. My name's Rich Mcintyre. I work for BJSS. We're very much involved in this health tech space, and I'm just really excited to invite you and to be a part of Leeds Digital Health. It's an exciting vision, and all exciting things often start small. I'm sure you've all got visions of Steve Jobs making the first Apple Mac in his garage, but I really feel that the health tech sector in Leeds is something special. I've moved to Leeds about 10 years ago. I got involved with tech here. It was very easy to get involved with tech. There was so much tech stuff happening. And now it's kind of quite unanimously recognized that Leeds is a digital hub in the north. And I think after being in BJSS for a while, I've realized it's not just tech, but it's also health tech. And I'm really excited about what we can do by building a health tech community in Leeds. Just by being here for a while, you soon realize we've got NHSD just along this road. We've got the likes of TPP, who Matthew's very kindly representing tonight. We've got EMIS. We've got many other health tech organizations here that we didn't realize existed. And what's really good to do is to show the innovation that we've been doing, showing the great work that we're doing. How are you using data? How are you using the internet? How are you using design to better come up with solutions that help clinicians, hospitals, and indeed patients to get better health outcomes? And we know that more than any other time, the world has woken up to this is super important. And so over the last year, we've all been working on digital health solutions and seen a real acceleration in the way that we're implementing and delivering those. But and it's not just about what we've done through COVID. That's great, absolutely great. But what's coming in the next year? What's coming in the next 5 years? What's happening in the next 10 years? Technology will be driving this, right? And we don't want to just be sitting doing our own thing with our eyes closed and see the great opportunities go past us. What is the next? How are we going to jump into the data revolution? How are we going to see identity management be far more seamless for the various staff that interact with our systems? And it's not like we can just take any generic tech trend and adopt it, because there are other considerations that we need to make as medical professionals in order to serve our patients better, in order to get better health outcomes. So this is part of celebrating being on that journey together. It's a place where we come together, we share some of the great product ideas that we've been having, the great deliveries that we've been doing, to network with each other, to find out, is there opportunities that we can interconnect some of our systems? Is there a way that we can bring more power to the systems that we're developing? By having a system working along in isolation might be, duly powerful and noted, but you then mix it with another system and see that interop happen, and you can immediately get 10 times the power, and that is exponential. So I'm really keen that through networking, through joining up, that we can see Leeds Digital Hub grow exponentially and be recognized in the country, to get better connections with Leeds City Council, with the universities. We can join together to push forward what future demand looks like in this tech space, so that we can hire the talent that we need to build better and better solutions going forward. So that's the vision. I really hope that you buy in and you're as enthusiastic about that vision as we are here at BJSS, and we just really want to welcome you to be a part of that. So today we've got three really great speakers, and I'm really excited to hear from all of them across a bit of a range, right from clinicians on the ground that will tell us what the patients are really wanting and needing, to TPP talking about how they've been developing their digital offerings through the pandemic and what that might look like going forward. And then also from Dave Black, sorry, David, it sounds a bit formal when you're called Dave everywhere. But yeah, Dave will share with us about how to build for a design for doctors, and that's going to be a super interesting session. So welcome to you all, and thank you to our speakers. And I'd like to invite Alison Kinlock to the stage. Alison will introduce herself, but basically Alison knows so much about how the NHS data kind of digital systems work under the hood, especially spine. So if you don't know what NHS spine is, please do look it up. It's like a huge I was going to say monster, but maybe that backbone of the NHS, a good monster that actually makes a lot of the NHS run and happen and deliver all sorts of great digital services and connect them. So over to you, Alison, and you will be talking to Dr. Mona Johnson, who's the Deputy Clinical Director for Patient Safety at Nhs Digital.
Hello, which introduced me. I'm Alison Kinlock. I'm one of the technical leads on spine, which its strapline is the backbone of the NHS. So I'm one of the team working on the big back-end systems, and we're often quite removed from the clinicians and from the patients, and that side of the impact that all the code we're writing, everything that we do and the decisions we do, how does that actually affect downstream? So I'm really interested to introduce Dr. Mona Johnson, who is the Deputy Clinical Director for Patient Safety at NHS Digital.
Hello, Alison.
Hi, Mona. So thank you for joining us today. And could you please tell us a bit about yourself and the roles that you hold?
Yes, sure. As you and Richard both said, I'm Deputy Clinical Director of Patient Safety, and I'm also a GP. So my other job or my training is in general practice. I'm not quite in Leeds. I'm officially based out of the Leeds office, but I work in North Derbyshire and I live in Stockport. So you'll see, those with eagle eyes will see a Manchester B on my wall. I'm from the other side of the Pennines, really. I'm an interloper. But yeah, I've been with NHS Digital for 7 years, and I joined the organisation from NHS Direct, where I'd been involved in implementing the 111 service across the country as part of the change process for out of hours. And so I kind of lived and breathed clinical safety processes and the clinical safety standards even before I knew that that's what I was doing. So then when I came to NHS Digital, working for NHS Pathways, writing clinical algorithms, I was their Deputy Clinical Director for a few years, and then I moved into the central part, which you'll know well, strategy, policy and governance, and now I'm leading work that we do in clinical safety around the safety standards, training, and I've created a system of clinical governance and oversight at our organisation for exactly what you were talking about. You know, how do we involve the clinicians and get that kind of frontline business intelligence, I suppose, to inform the shape of what we do at NHS Digital.
Yeah, because we're very focused on the technical implementation on the back end, how we're going to do it technically, without thinking how the decisions we make over codes that are used will affect the views that the clinicians see on the patients. So if you could tell us a bit more about your experience of your clinical safety role during the COVID pandemic.
Yeah, so it will come as no surprise to everybody that it's been a really busy time for NHS Digital over the last year and a half. And I think it's been kind of an odd way to say it, but it's been a bit of an opportunity to bring the role of digital transformation to the front of everybody's agenda in health and social care. So we've launched a number of different products which are built on some really great work that has already happened here. One of the things that I think we should all be really proud of is the vaccination booking service that we run through nhs.uk. But we've also been involved in putting together, pulling out data from patients' records, using that information then to with academic organisations to determine the shielded patient list. And this list has helped to kind of let patients know, let practices know, if you're a GP like me, who are your really at-risk population, who you need to prioritise for vaccinations. And I suppose all of that, it's partly it's about, having the right clinical information and bringing that to bear with the technologies that we design. But there are also kind of obligations or duties on us as the manufacturer to meet the safety standards. And I suppose that's really been what I've been doing over the last 12 months. We have a very active and involved clinical safety team and clinical safety group where we do the kind of the assurance work for the organisation. So looking over safety cases for things like, data collection, sometimes changes that we've made in the summary care record, the vaccination booking services. And so it's just making sure, it sounds not very exciting, but we're the sort of checks and balances part of making sure that all of that clinical safety work has happened to ensure that patients don't, or people rather than patients, just people, because it's everybody now, that you're capturing the right person, that you're letting the right person go down the route that you need them to go through, and no, you're not putting somebody else at risk because of the kind of way that you've designed the system. And that's been a really interesting part. How much information do we put in the summary care record about the vaccination that somebody's had? How timely does it need to be? When do you put it on? How much information about allergies, etc. So all of these things have been kind of part of our what we've been doing.
And I think, and when we talk about summary care records, I think what we become very aware of is we hold a summary care record to serve out to people. It's the large number of people who might be able to view that and making sure the right people can view that information and that it's presented to them in a way that they can interpret that information correctly as well.
I think that's, sorry, go on.
Yeah, and it's making sure the patient safety is thought about at the very beginning. And it's not that, oh, have we now gone to patient safety? So we can embed that at the beginning of the process.
Yeah, and they've had some clinical safety colleagues and a GP colleague of mine, Rob Jeeves, who's been with the programme. He probably knows that product better than any of the rest of the clinicians in the organisation. But thinking about, and I see it from the other end as well. So I've worked in general practice, so we are the single source of truth, if you like, in my GP job. But also I work in out of hours, so I see it at the out of hours, and bringing that kind of knowledge and understanding when we're making those sorts of changes, I think is really important, and having that sense check to ensure that we've been doing it in a way that then makes that data and information kind of usable by the clinicians, relevant, and presented in a way that makes sense. Yeah, and I think, as you say, having it there from day dot is something that we kind of aim to do. I think, having lived through the pain of when we don't embed it from day one.
Yes. Indeed, it is. So as we're talking about that, what sort of talking about vaccination, what would you like the product teams to actually know about clinical safety when we start developing solutions?
Yeah, so, and I think I'm really interested to hear, you're going to have a talk about designing for doctors, and as a doctor I have a bit of a vested interest in that, but I think it's like any type of co-design that you do, you kind of get your stakeholders involved from the beginning and involve them early. So both, sometimes we'll kind of wear a number of different hats. So I'm a GP, but I'm also involved in clinical safety. I might also have other responsibilities elsewhere. So yeah, we probably will bring all of our kind of different knowledge into whatever we're working together on. But I think the real message is, especially for clinical safety, because of the safety standards, which you can certainly have a look, they're all on our website. They might be a bit tricky to decipher, but we're really happy to help people to understand them. But the key thing is to get your clinical safety colleagues involved early. What we've learned is that if you try and do the clinical safety work after you've decided what the solution is, there's a lot of unpicking to do, and there's a lot of effort and time that's added on to projects, because you kind of need to go over stuff and so many changes need to be made, which to me, and I'm a neat and tidy person, I like to have something clean and spick and span. I don't want to have a load of like workarounds, and I'm sure people who work in technology will feel very similar to the way that I do. But yeah, get them involved at the beginning, and experienced clinical safety officers will really walk you through that process. They kind of know how to do it, and they'll facilitate you through the kind of sessions. I think I don't know what you might think, Alison, but I hope that what we do enriches the kind of knowledge and understanding of the people that we work with as well. And I hope that we come up with things that nobody else has thought of. And I often feel that way, that gosh, there's other things, once we get the conversation going, there's other things that colleagues from the multidisciplinary team will bring up that I would never have thought of. So.
Yeah, we had exactly that example today, where we were talking about something new to be implemented, and the clinical safety officer said, how are we going to make sure that the right patients continue to get contacted with what we're going to do, because of these scenarios, medical scenarios, that we had no visibility or awareness of, but the clinicians and the GPs straight away could say, but this happens on the ground, even though it shouldn't happen on the ground, it does. So how is the system going to cope with that? And bringing in that real life experience really does help, and that completely different sight on it, especially when we're talking about developing things like APIs at the very beginning, because they can be quite hard to change quite a long way down the line, whether rightly or wrongly. So as you say, for me, it's very much at the beginning, and not seeing it as a blocker. It's the clinical safety, it's to make a much better solution. So as I think I've seen, you've probably seen, there's been quite a difference in opinion and approach over the last couple of years through COVID around patient data and what we share. And we can see that with summary care record, the advanced information being more readily available. So what does the future of tech and clinical safety look like for you?
Yeah, so I suppose I've got two answers. One's the kind of maybe more corporate view, which is about and what I'm employed to do, which is patient safety. So I suppose firstly, we've been working together with NHSX to publish a digital clinical safety strategy, and that's up on their website, and I can provide a link to people, but there are 5 kind of key messages there, and the summary of them is that we really want to learn from how the systems are behaving, how technologies are behaving, either to enhance patient safety and improve outcomes for care episodes, or to learn, you know, what's going wrong basically, and do that in a systematic way that's joined up. I think we've probably in health and social care, we've often thought that technology is kind of not front and center, and that's difficult for me to say, because as a GP we really, you know, I have my electronic health record, it's the main tool that I use, so I know what a big influence that has on my day-to-day work and how it can be an enabler for patient safety. So yeah, so we're going to be working together with NHSX and NHS England to improve those systems for reporting and learning and improving on safety and outcomes. But the other one is my own personal kind of ambition for the future, which is about something that we had a session today with our clinicians at Nhs Digital about, which is learning health systems. So this is a kind of a concept that you where the technology is a bit of an enabler, and you use the combination of culture, informatics, safety to improve and iterate. So I think that really fits with you know, how we develop technologies these days, in that agile methodology to kind of iterate over and over again with the kind of purpose of continuous improvement, but really using those learning health systems in a kind of broad conception to and really bringing the informatics part of that, the data, and turning that into knowledge, which turns into practice. I think that's the bit that I'm excited about. So it's not quite machine learning, not quite AI, but it's, I think, really a way to think about how we bring the informatics, the data, to really to bear on a kind of more to me, it feels quite exciting to talk about things in that way. Having said that, we're a long way ahead of a lot of other countries in England, because we have got an NHS that's so joined up, even though it might not feel like that all the time. Yeah, that's my that's my ambition. And I suppose the spine is like such a huge part of that, isn't it? Because it's yeah.
It is in the middle. But I think that's quite an important takeaway for me, is one of those thinking about when we are doing these new systems, is how can we use the data, the information that we're gathering to help do these feedback loops, so that we can learn not just what's going well, but what's going wrong. And one of your first points about the change in learning what the problems are, and that's quite, we're now able to more do that, but we have to think how we're going to be able to do that when we implement and what's available, which is another side of thinking about the requirements.
Yeah. Yeah. And the implementation bit is, it's no small part. It's, I think it's the bit where, and having done implementation, you know, for a few years over a major systems change, it is where some things can come unstuck quite quickly, and it's the real human interface part of kind of making a system really work. And I think that's why doing that groundwork at the beginning, and I think as things have changed now, or I've been working in this kind of space for about 10 or 11 years, and having seen how things have changed from here's the product, off you go, to let's shape the product together and make it right and make it fit and make it fit for use. I think that's been a real step in the, you know, it's been a fantastic journey to witness, really. Yeah.
And that's what we need to continue. Yeah. Thank you very much, and that's been really interesting. So back over to Rich.
Thank you very much. That was really good, really interesting. Just that level of collaboration that we need to see together with these health professionals is so crucial, isn't it? So really great to hear from Dr. Mona Johnson. Without further ado, we move on to our next speaker. Director of Strategy for TPP, Matthew Strickland, is going to talk about how the COVID-19 pandemic changed healthcare's approach to digital, and what we need to talk about now. over to you, Matthew. Thank you.
Thanks, Rich. Right. Hi there, everyone. Thanks very much for having me today. So as Richard said, I'm Director of Strategy at TPP. I've been with the company about 6 years. I started off in a more, I've no background whatsoever in technology and even less in healthcare. I was language and history and got into the industry because I fancied a job for 6 months before I started my PhD in something else completely separate. But nevertheless, here I am 6 years on in this role. And I think that's sort of testament to what Leeds, what digital and what healthcare can be like to work in. So I want to talk a little bit today. I'll talk about three things. I'll start off, I remember when I started, a little bit lay of the land, when I started ignorant of everything, it was the NHS, and surely the NHS was using one system across the board, and it was NHS technology, and after a long period of time you realize it doesn't work like that, and there's a lot of collaboration that's involved. And previously with Mona and Alison, ourselves at TPP work with all across NHS Digital, and there's been many interactions, some successful collaborations and then some not so successful bits, but it's been a long relationship. And I think I want to talk a little bit about coming into the industry, what it looked like, how COVID changed things, and then completely hypocritically talk about why I think we need to move on slightly from looking back at the successes of the last 18 months and talking about realistically what can we try and do moving forwards. And I'm not going to be hypocritical again, because I'm not going to use the phrase new normal, but something about what can we take that's positive, but also we have to realize that there's elements of that are not sustainable, and we need to think about that. So first things first, we as a company supply the electronic healthcare records to about 7,500 NHS organisations. 6 years ago, I thought that was probably a GP, a hospital. I probably was somewhat cognizant of mental health settings, but that was about it. Now I know there's a plethora of organisations right across the board who formulate part of the NHS. And then we've also got, the social care side of things as well. So a huge array of organisations, and with that comes a huge array of different systems and different companies that operate in this space. I still to this day find it a little bit difficult from a citizen or a patient perspective to realise that in certain scenarios, the system that your GP practice uses affects which app you might be able to access your healthcare record for. And I think that's sort of, whilst we've got a lot of the technology, there's still a lot to be done in terms of, and I think the pandemic showed, making it explainable to citizens. Like, we don't, as citizens, we don't want to know what IT systems in place in which healthcare setting. We just want to be able to access the data, get things as quickly as possible, book our appointments and crack on, and we're not too bothered about that. And I think, as Mona said earlier, we are very joined up in this country in comparison to other places, but there's still a lot to do. And I think going into that, if you build on from that slightly, I think when the pandemic struck, a lot of the things that my friends and family were reading about on the news, for example, they didn't necessarily know how that translated to what we were doing as a company on a daily basis. So you hear headlines along the lines of, I don't know, there's 20,000 retired GPs who want to come back and start doing consultations. We need to get them access to systems securely. That's different IT systems, different areas. How do we get them the right sort of going out to spine, the right permissions and right access on that? How do we ensure that they're accessing data, the appropriate levels of data, that they are being regulated, and all the things that we take for granted? A lot of that falls onto system suppliers like ourselves, but also NHS Digital and other people. So I think the one thing I go back to on the pandemic, and I've said it a few times, is we didn't start using Microsoft Teams and Zoom and everything like that because the technology suddenly started getting better in March of 2020. The technology was already there. The technology existed. Sure, they ramped up and be able to handle load, but there was a very acute need that I couldn't come out and do things like this. We couldn't see our friends and family. So the need was I wanted to be able to see someone's face, and therefore there was an outlet to be able to do it. And I think when we're developing technology, and the thing about the pandemic that enabled us to achieve so much is there was a very clear and acute demand for certain bits of technology, be that returning doctors, be that video consultations, be that as was mentioned earlier, the additional information to upload in the summary care record, so they had more information available, be that things like one of the projects we were involved with, again, with Nhs Digital was, I remember the Easter bank holiday weekend. So it's 4 days bank holiday, which for most people didn't mean anything because they were going to be spending them sat at home, not on Zoom rather than on Zoom. But for many people, that meant that they needed their prescriptions to go to the pharmacy that wasn't their usual pharmacy, but was the one that was open over the bank holiday. Because if you imagine, not every pharmacy stays open on the bank holidays, but there'll always be one in a particular area that does actually stay open. So they wanted to change what's called their nominated pharmacy, but they only wanted to do it once because they didn't want to change. I like going to Lloyd's in Yeadon High Street. That's the one I go to, but that's closed. So I'll go to one in Ilkley for this weekend if I need my medication. But I didn't want it to change for the long duration. So that was a bit of work that was, it might have taken a number of months to work out what the demand was prior to the pandemic, who was going to use it, do the assurance piece, and then manage the rollout. And that's not necessarily unreasonable. A lot of that does take time. But when you've got a situation that you're worried about 4 days and people maybe not be able to get medication, there's not necessarily the support structures in place, that people can't get out of their houses and things. A lot of the obstacles that we were working with prior to things, and some of them are reasonable obstacles, sort of melt away, and we end up finding and cobbling our way through. And I think what is remarkable is when we look back at the pandemic, most of the decisions that were made in digital, in my opinion, across healthcare, have been largely vindicated. Most of the projects have been successful. There's not been many things that I look back now and think, Christ, we really shouldn't have done that. That was a mistake. I'm not talking from a personal perspective, a TPP perspective. I'm talking right across the sort of healthcare landscape. I think projects such as Open Safely, which has been, if you don't know about that, have a look at that. It's been fantastic about the use of data. We've mentioned summary care record, additional information, and there's a huge number of those. I think they've been good. And I think what that doesn't mean is that we chuck out things like, information governance, patient safety has been touched on before, questions such as digital inclusion and exclusion. But I think we need to understand that we would all in tech kind of like to work in some ways in the rules that were during that first 6 months of the pandemic, because we got more done more quickly, and everything seemed possible. But that's only really because there was a very acute need that was well defined. People were engaged from the start. There was a sort of a collaboration that people really wanted to work together. And I think moving forwards, we need to try and foster and sort of remember some of that. So it's things that we mentioned already, getting people engaged earlier, being sure what the problem you're trying to solve is, or what the thing is you want to do better than is today. It's also about understanding that the NHS tech's favourite words are pace and scale, and there's some truth in that. But if we take a good one about exclusion, digital exclusion, we often think of the pandemic of it maybe going online excluded certain people from accessing healthcare in certain ways as a common narrative. We want face-to-face appointments. We've seen some of the coverage of what's going on in primary care. But I remember in about October last year, I was chatting to a mental health physician somewhere down south, I think it was around the Surrey area, who was talking about the fact how remote consultations meant that certain anxious patients didn't need to get on a bus. They didn't need to pay for a bus fare if they didn't have the cash for it, but they could still see the face of the person they were actually caring for. And the idea of having to come back to a face-to-face setting made it more difficult. And, that's the argument for, not the argument for tech, this argument for hybrid, for having more options available to people who are giving care. And I think that's what we need to think about. We can try and bring in some technology that solves something for a particular group of people, whilst making sure it doesn't make it more difficult for others. And if we get it right, we can find a way of providing more options for people. That means that everyone's got their own way of navigating through this healthcare system, and try and make it as simple as possible. And why I say we need to stop speaking about the pandemics hypocritically, as I've just been prattling on for 7 minutes or whatever it was about it, is because when I also think about times and some of the teams I was working with and some of the people I know at NHS Digital and the clinical staff and the hours they worked, you know, the number of, I'm not technical, my job is to talk about the work that other people are doing, but during the pandemic, it was tweets, it was emails, it was messages, can we have this, can we have that, for people who really had acute needs. We can't quite work like that. That's not, it wasn't all roses, it wasn't all collaboration, it was tough work. So I think that we need to not think of the pandemic as a sort of be sitting and talking about everything that we've done in digital and sort of sit back and sort of gaze on what we've achieved. I think we want to try and take the best bits of it and learn from it, and think about what, when we're building technology, what more does it offer people, what does it offer clinicians, patients, etc. But try as well to move on and not remember that everything wasn't great about it in the tech world. Not everything was fantastic about it. And that sounds kind of obvious. And I would never dare say that to a very, very clinical audience because you'd be shot and thrown off stage. But from the tech audience, there's sometimes a habit to think, wasn't that fantastic? Wasn't that rosy? And I don't think every aspect of it was. I think there's bits to take forward, but there's bits to leave in the past. Collaboration's good. Being sure that what we're developing is what people want, minimizing assurance and bureaucracy where we can, but not just casting everything aside and just going full steam to every single problem. We have to work out and prioritize things, and make sure that what we're doing is going to be there for the long term, because the only thing, if we look back, is some of the things we did during the pandemic are not necessarily going to be as ubiquitous as they are moving forwards. Not everything is here to stay. So I think that's a few of my thoughts. I think I'll do it sort of arse over tit. I think that Leeds has shown the way in digital health. I think it's been great to be here, and it's been in Leeds with, you know, the companies that Rich mentioned before and so many others. And it's certainly good to get out and chat and share some ideas with some other people. So it's fantastic to be in person. It's nice to hear everyone's thoughts, and it's been a good couple of weeks for Leeds Digital Festival. So that's my rambling thoughts on tech, Leeds. And Rich, I hope it wasn't too long, and I'll hand back to you.
Absolutely perfect, bang on time. Thank you very much. Yeah, so really great talk, and thank you, Matthew. Really enjoyed that. I think that's, and Dr. Mona Johnson talked about it a little bit as well, about sort of the agile process and of iterating on what we're doing and kind of what are the learnings that we've taken and how can we take them forward. So really excited to see what some of those solutions might look like in the future as we progress and move forward. So last and not least is our very own Dave Black. If anyone's heard Dave speak before, you know you're in for a treat. He's a very engaging speaker, and he has some really insightful ideas to talk about, especially around design. And his talk today is entitled 4 Simple Rules to Save Lives with Design.
Thank you, Rich. Can I stand up? Will the camera get me if I stand up? I've got to sit down. Oh, that's deadly. Okay. Well, for the people watching online, I'll probably move around a little bit, so I might actually go off camera a little bit. Okay. Is this the clicker for the slides? Okay. So, is anybody here a clinician? Are there any doctors here tonight other than Mona online? No? Good, right, so I can say anything I want, fantastic. So hi, I'm Dave, I'm a designer, so I work for a company called Spark. Spark is the innovation lab offshoot of BJSS. I do lots of different things. I do user interface design, I do UX design, I do research, I do service design, and mostly what I do at the moment is I work with the NHS. So I've been working with NHS Digital for about 3 years, working on a really big program. And the program is all about reimagining how appointments and referrals can work within the NHS. There we go. So Spark, just so you know, is this leading global design and innovation consultancy. We're attached to BGSS. We've got lots of interesting clients, of which NHSD is my favorite. And this is the project. So what we're trying to do is we're trying to build an any-to-any bookings, referrals, and appointments service for the NHS. So everywhere in the NHS that there's an appointment or a referral, we're going to be involved in that side of things. So this is not an easy thing. The NHS is really big, and this is an area where the NHS struggles. Hands up, who's been to the doctor in the last 6 months? Right, was it really easy to get an appointment? Was it quite difficult to get an appointment? Pretty difficult, okay. So I'm going to do something first. For folks at home, I'm going to go off camera for a second. Right, so we're going to play a game while I'm doing this, right? So I've got two things. I've got some hand sanitizer and I've got this ball, right? I want you to do something for me while I'm talking. So I want this ball to go right round the room, right? Including the people over there and Rich as well, right? I'm going to put it there, pick someone to start. I want that ball and hand sanitizer to go right round while I'm talking, okay? See, she's messed up already, look at that. That's amazing. Right, okay. I will explain why we're doing that later, I promise. It's not completely insane. Okay. Here's our slides, okay. Are my slides working? Right, okay, so let's talk about clinicians. So the first thing to know is to design for somebody, you really have to know them. And ideally, you should like them. You should understand them, understand what they're about. So in pure numbers, the clinician numbers within NHS are enormous. So there are 1.3 million people within the NHS. There's 123,000 doctors, a few hundred thousand nurses, and there's lots of other people who qualify as clinicians as well. There's physios, and there's all sorts of optometrists. There's lots of people, high street opticians, all over the place. There's huge numbers of people involved in this. And they're very, very diverse. That is just from the NHS Data Dictionary. That's a brief outline of the different clinician roles. There's at least 350 different clinician roles inside the NHS. And the patients are very diverse too. I love this stock image, by the way. I found this online. What do you think that guy's doing? He's supposed to be a patient, apparently. Is he singing opera? Is that what he's doing? Oh, I don't know what it is. But they're a very, very diverse bunch. They're very interesting people, just like the clinicians. So the first thing that you learn is that this guy is not a clinician. Who watches House MD? We all ever watch this? Okay. So this is Hugh Laurie. He plays this doctor on TV. Who's a lot like kind of TV type doctors. So basically he can kind of do everything, and he works for this hospital in the US, and he's very sort of sarcastic and dry, and he has sort of interesting cases, but he's not a proper clinician. And the reason he's not a proper clinician is relevant to what we're going to talk about. So his specialities, he's actually hired as a nephrology and infectious diseases doctor. So he's a kidney specialist and he looks at infectious diseases. But over the course of the series, you see him do all these different specialities as well. So he does everything from brain surgery to diagnosing rabies. He's a fantastically sort of talented guy, right? The other thing that he does is there are no radiographers in this hospital. Do you ever see on TV, they always check the radiography slides, check the x-rays. Doctors don't do that, radiographers do that. House is not a proper doctor, but this is really important because House can do something that real world clinicians can't, which is he can cross the boundaries between different specialities. Because he knows every speciality, he's able to cross the boundaries. And the boundaries are really important here. Where's my ball? Shake my ball, give me a jingle. Okay, so we are moving around. Okay, good, just checking. Okay, so clinicians are not Dr. House, and Dr. House is not a proper clinician, right? So they're usually nicer than Dr. House as well. So real clinicians look a bit like this. So I work with clinicians all the time. I've worked with lots and lots of clinicians over the last 3 years. These are some, was one of the senior clinical councils that I sit on. The guy on the top left is Sir Sam Everington, who's a really famous GP down in London. We've got a dentist down at the bottom right. There's a gastroenterologist at the left. So they're real people. And they have real problems. They have real human concerns. And the things you have to know about them, first of all, clinicians are really smart. So it's not very easy to be a doctor or a nurse, actually. Most clinicians are pretty educated and clever, but they do quite a nice thing, which is they get a really good balance between being very academically well educated, but they're also very empathetic. And they're all different. The other thing about clinicians is they're all very, very different people. So they don't have, no two clinicians are clinicians for the same reason. They're all in different specialities, and they all do different things for different reasons. And they approach their work in completely different ways. And that makes designing for them really interesting, because it's very difficult to build a single service which will fit everybody's needs, because they all have different needs. This is the one thing they do have in common. So being a clinician is enormously stressful. It's really, really, really stressful. So what is stress? Stress is that feeling of pressure. So we all experience stress, and it comes from difficulty in effectively dealing with the situation you find yourself in. Now, doctors in particular are prone to huge levels of stress. So 80% of doctors say that they have too much stress, and 1 in 3 of them actually have a disorder related to stress. Now, I think that's quite sad. I think that's a problem. And it's worth understanding where the stress comes from to be able to look at how we can solve it. So where does stress come from? So Psychology 101, this is really basic stuff. Stress comes from 2 key sources, so from ambiguity and complexity. So ambiguity means you're not really sure what you're supposed to do next. And complexity means that the thing that you're supposed to do has lots of moving parts that you have to work with. This is to do with mental models. So ambiguity means it's hard to build a single mental model that you know is going to work. So you build lots of them, and you have to kind of juggle them because you might need any one of them. Complexity means that the mental model itself has a lot of moving parts. So there's lots of things connected together. And these 2 things together, they create huge amounts of stress. It's not caused by this. If anybody here is a designer, and there's any designers listening, please don't say this. Tech literacy is UX speak for stupid. If you're saying that your users have low tech literacy, you're actually saying they're thick. There is nothing wrong with users. Most of the users, 80% of adults in the UK own a smartphone. They use FaceTime, they use WhatsApp, they play Candy Crush. There's absolutely nothing wrong with their tech literacy. They just don't see your systems having enough value to invest the time it takes to learn how to use it. If you go to a cash machine, go to an ATM, you'll see that we've had ATMs for 50 years in the UK, and there's still people who struggle to use ATMs. They're not stupid. They use other computers all the time, probably at their work. The reason they struggle to use them is because the ATM doesn't give you enough value to be worth learning to use it really well. The same is true of a lot of health systems. Now, here's the difficulty. So we talked about ambiguity and complexity, but ambiguity and complexity are built into the NHS right at their very, very bones. I'll explain why. So this guy here is a brain surgeon. He's a real brain surgeon. He's an American guy. This is him performing a very complex, very difficult brain surgery procedure. Now, that guy is exactly who you want operating on your brain if you have a brain tumor. But if you've got a heart problem, he won't go anywhere near you. There's a good reason for that. It's because he's not a qualified cardiosurgeon. And actually, if you ask him about something to do with your heart, he won't know because he's a specialist. NHS works on speciality. It works on getting people to be really, really good at the task that they're immediately involved in. So House, who is good at everything, no, send it back out there. Go on. Sorry, Richard's coming back to me with the ball. Go on, send it back round. I'll explain, I will, honestly. So ambiguity and complexity are built into this, the whole NHS structure because you have organizational boundaries between specialities that the NHS firstly can't get rid of, and secondly, they don't want to get rid of them because Dr. House doesn't exist. You have to have people who are just brain surgeons or just heart surgeons or just physios and who know that job really, really well because there's only one lifetime in which to learn that job. Again, here's a slice from the NHS Data Dictionaries. These are the specialities that we have within the NHS. And inside every speciality, there are people who are experts at just doing that one thing. So they are necessary. These organizational boundaries are necessary, but they create knowledge gaps, which are really hard to bridge. And what that does is that produces the stress that we're talking about. So the average clinician has got 7 IT systems. This is just for referrals. Some of them have a lot more. We've seen up to about 13, 14 on the desktop just to move patients around. And the entire NHS system is dependent on this idea that you've got a clinician who is a GP, or they're an ophthalmologist, or they're a musculoskeletal, or whoever they are, and they're supposed to make decisions on behalf of patients who they're passing over to other specialities. But the doctor in question doesn't know that speciality by definition, because that's the way the NHS works. So you don't know the internal rules to the department that you're passing your patient to, but it's a life or death decision in some cases. So if you get it wrong, ... So I hope you can start to see the problem. And what we then end up with is this kind of picture. So this is a picture from a recent project I've been working on with a fabulous team at NHSD. It's about optometry and ophthalmology. So it's all about capacity and demand. How do we get capacity and demand through this system where you've got lots of people making decisions about sending people to areas they don't know anything about? That's a really, really difficult problem. And for a designer, that's a chunky problem to look at. So the reason I'm asking you to pass the ball around is because that's a little model of how the NHS works. So when you're passing around, you see people kind of sneaking around. So there's lots of ways you can do it. So do you pass the hand sanitizer with the ball? Do you sanitize the ball or do you sanitize your hands? Do you stand up or do you crawl? Do you throw it? Do you pass it? There's lots of different ways to move the ball around the room. But I didn't tell you what the rules were. And because you don't know the rules and you don't know each other, you've kind of got to wing it. And that's exactly what we expect clinicians to do within the NHS a lot of the time, is to kind of wing it and kind of learn as they go along. So the ball's been around a couple of times and you're getting to know each other and you're kind of moving around faster now. So it's a nice thing. But this is the difficulty we have in the system. Okay, so back to this guy. So the patient interaction is ambiguous and complex too, because patients are very ambiguous, very complex creatures. But I'll cover that more in depth just in a moment. So what clinicians do to cope with this is they get very good at pretending everything's okay. I think that's a little bit sad because they are very, very stressed and they do an extremely difficult job, but they're brilliant at pretending that everything's fine and we shouldn't worry about it. So when you're designing for clinicians, one of the things you have to do is you have to spend a lot of time getting to know them. You have to really spend, so I spent about 2 years just doing 3 or 4 meetings of about an hour each a week, just listening to clinicians and finding out what their actual concerns were. And you have to do that before they start dropping the mask and start actually telling you what's going on with them. So how do we do it? How do we get around these problems? How do we pass the ball around? So the first thing to do is we really need to design for real. We need to design for the reality of the situation. So we've talked about ambiguity, we talked about complexity, and we talked about the stress that produces. So the problem there to solve is basically stress, but then we have to look at where that stress is coming from and get to the root of that problem. So on the project that I'm working on, one of the things that we quickly came to realize was that there's no point in trying to solve all of the clinicians' problems because there's too many of them. There's 130,000 clinicians in one area alone. You can't solve all of the problems. What you can do is you can create a system which has the capabilities which give them the tools to solve their own problems when they encounter them. So this is going to be at least part of the future of healthcare for the NHS. This is a set of capabilities which the project is spinning out. I know you can't read them, but I'll explain some of them in detail in a moment. And again, instead of designing a bunch of solutions, a bunch of products which then get built, what we're doing is we're saying the system should have the following capabilities in 5, 10, 15, 20, 30 years. We should be able to see these capabilities to make good experiences and to give tools to the right people to be able to solve their own problems. So in a system that is this large, you can't list all the problems. We did try. When we first started doing the research, we got about 2,500 problems that we hashed out, and we linked them all to parent problems and grandparent problems, and it was a huge mess. There's far too many problems in the system. And any doctor or nurse practitioner or any physio will tell you that they have their own problems which are unique to their area. So the only thing you can do is build up this tool set to help them solve their own problems. The other thing you have to do is you have to accept that your changes will actually create more complexity and ambiguity because you're introducing something new into the system. So you introduce something new onto a desktop, you introduce something new into a process. And actually you have to accept that because we already talked already about the necessity of the ambiguity and the organizational boundaries because of the specialty system within the NHS. You can't get rid of it. That's the reality. So what you have to do is you have to design for that reality and find ways around it. So here are the 4 simple rules. So rule number 1 is to understand real clinicians. Here's a quote from a real clinician. So the clinician we were talking about, we were asking whether there were behaviors associated with particular conditions. And they said, yes, absolutely. There are some patients who exhibit specific behaviors associated with their condition. Things like people who are diabetic. Obviously, they have behaviors around medication, they have behaviors around managing their diet. And they said this, but they said it's not just their conditions, but where they're from as well. If I see a patient on my list with a history of addiction from one particular housing estate near my surgery, I know exactly what I'm getting. My heart sinks. Now, if they said that openly, the reason I anonymized the quote is because if they said that openly, people would say, that's awful. They shouldn't say that. Well, they do. And people would then say, well, they should stop. Well, they're not going to, because they're not wrong about it. This is not actually incorrect. There are specific behaviors associated with how people use healthcare who are from particular socioeconomic backgrounds. And you have to design for that reality in your system. Not a nice thing, but it's reality. So what we have to do is we have to design for the doctor's disposition as well as for the patient's. So doctors have particular attitudes towards particular conditions. They have different methodologies for dealing with the conditions. They have different attitudes towards the different behaviors they encounter. So actually what you have to build into the system is an assumption and an understanding of the doctor behavior as well as the patient. So we've done that within our system. So you can see in there, you've got advanced patient profiling is on the pink column. So that's a holistic profile of the patient. But we also have is that you've got a holistic profile which is related to the doctor. You've got the doctor disposition, which is built into it too. So rule number 2 is to design in complexity. So it's not about designing out complexity, it's about designing it in. Complexity is unavoidable in this particular system. You can't get rid of the complexity. What you need to do is understand what the complexity is and design for it. System complexity can be unavoidable. One of my pet hates is self-checkouts. Hands up, who likes self-checkouts? Anyone actually like? No. 80% of people who use self-checkouts report you having difficulties using them. And there's a good reason for that. It's because there's a common misconception that self-checkouts are automation. They're not, they're outsourcing. They're not automatic. All the supermarket has done is outsource it to the customer. They outsource the checkout to the customer, and the customer works for free. It's a bargain for the supermarket. It's rubbish for the customer, but it's great for the supermarket. So if you're going to do this, actually automate rather than just outsourcing, and particularly don't outsource to clinicians. So again, when we look at the system that we're developing, every time we make a change, we have to ask, okay, is this going to add complexity? And if there is complexity, make sure that the system takes the complexity and not the clinician. Don't ask them to do extra admin tasks. Don't ask them to learn extra things. So you have things like you can see there, things like referral builders. If you're going to open up the landscape to any referring, where any clinician can refer to any other clinician, lots of people are going to refer to settings that they don't know anything about. So you really want to have a system which knows the rules and can replay the rules to the clinicians. Things like data updaters as well, and things like workflow managers. Again, if the clinician doesn't know the workflow for that setting, the system should tell them what the workflow is. Rule number 3 is to design in ambiguity. Again, it's not about getting rid of the ambiguity, you just have to accept that it exists. Again, here's our specialities list. That there is ambiguity between all of these specialities, and we accept that that's reality, we accept that's what we're designing for. So Dr. House doesn't need help with his referrals because he can operate in every single speciality. He knows more actually than every other specialist doctor in the hospital. He doesn't need support, but all of the other clinicians are going to need support with their referrals, particularly when they're referring to areas they're unfamiliar with. So the system should deliver best practice. It should be a system which, when you ask it, tells you the best way to do things. It's got heuristics built into it, it's got analytics built into it, it's got success metrics. They can tell you what the best thing to do with this patient is. So the system becomes the specialist instead at crossing the boundaries. So if the clinicians, you tell the clinicians that they have to figure it out for themselves, again, that's outsourcing, not automation. So again, within the system we're developing, there's lots and lots of automation. There's lots of automation around automated decision support, for example. So a clinician can hit a button and they can either talk to a specialist or they can get a machine learning recommendation of what the right thing to do is. And it's all to do with pathways, no coding, everything you need to know. All of the tech is built into it. And last but not least, design in real patient care. So again, this guy's not a patient. I like this image, but he's not a patient. Those are real patients. That's people fighting in the city centre on a Friday night. Those are real patients. GPs have to deal with people like this all the time. Clinicians are dealing with guys like this in A&E every single night of the year. That's actually who you're designing for. You're not designing for this nice, clean guy in the surgery who's just shouting for some reason or singing, I don't know. You're going to be dealing with people like that. And you're also going to deal with people like this, people who are profoundly depressed, people who struggle with their health, people who are in trouble. and don't know how to get help, or perhaps don't want to get help in some cases. So you have to accept that some of the real patients will struggle to access care, and some of the clinicians will struggle to get access to patients as well, both in terms of getting hold of them physically and also in getting them to follow treatment regimes. So patients don't know how to be patients. Patients have complexity and ambiguity problems as well. You can't expect a patient to know exactly what they're supposed to be doing with their care because they're patients, not clinicians. So you have to build that into your system too. And again, things like the decision support in the system should apply to patients as well as to the clinicians. Again, don't expect the clinicians to make every single decision on behalf of the patient. Make sure the patient is more capable and is able to meet your clinicians halfway. So lastly, and most importantly, the thing I would ask everyone to do if you're designing for clinicians is to trust them. And I say this with affection. I'm very, very fond of the clinicians that I work with. I've worked with them for a long time, and they've been disarmingly honest with me about a lot of very, very difficult things. But in the last 10 years, this is just the last 10 years alone. So lung cancer deaths have dropped through the floor. And that's partly to do with dropping smoking rates, but it's also to do with greatly improved clinical efficacy. Neonatal mortality has really dropped. It's gone down 15%. UK heart disease dropped nearly by half. And stroke mortality, this is largely due to medical interventions, has decreased by 46%. These are huge increases and improvements in healthcare, and you're seeing this all across the NHS landscape. But it's dependent on this one thing. You must get that patient in front of the right clinician at the right time. Now, if you do, amazing things can happen. You can literally be bleeding to death from gunshot wounds, but if you're in an operating theatre with a trauma team and all the apparatus that they need, you can be saved. You can have horrible, aggressive pancreatic cancer, horrible cancer, can kill you in 2 months. But if you're in an oncologist's office, you can have a great life, a great long life. People live 30 years after pancreatic cancer now. But it's dependent on getting the patient to the right clinician at the right time. And that's what the system doesn't do well at the moment. So in my opinion, what the figures show you is that the clinician is already doing their jobs. When you get the patient in front of them, the outcomes are amazing. But I think it's time for designers to do our jobs a bit better too. Thank you very much.
Thank you so much. I don't know how people are for time as to whether you need to kind of get on and do your various things. I don't know if like myself, I was incredibly challenged by that talk. I kind of was almost like, yeah, I kind of get this health tech thing. I know SNOMED codes, I know FHIR APIs. Yeah, it's easy. And then it's not easy, is it? It's incredibly complex. So thanks very much for that amazing talk. If there is 1 or 2 questions that people are dying to ask, please do stick your hand up.
You're very welcome to grab me afterwards if you want to.
Please grab Dave afterwards. But I just want to say thank you very much for attending either in person or online. Please do hang about and network, get to know a few people. It's really good to know who's doing what in this scene. And Harriet, are you kind of implying that there might be some, we've got to a bit of trouble making some nice food for you so that you could save a few quid and not have to make dinner when you get home. So please do stay and have something to eat. Please also do make use of the pool table and the kind of relaxed social space. And thank you again for coming. And we are looking forward to doing this again in the next couple of months or so. If there are things that you'd like us to talk about, please do let us know. If you'd like to talk about some of the successes that you've been seeing at your workplace, or even the challenges, we'd love to hear about them. We'd love to listen. We'd love to talk about our experiences and share them. So please do get in contact. We have a website, which is leedsdigitalhealth.com. I will be putting up an email address on that website very shortly, so you can get in contact or get us on Twitter at Leeds Digi Health. Maybe I might even go really futuristic, or it's not futuristic at all, is it? It's kind of now, and set up an Instagram account. I think WhatsApp is maybe pushing it a little bit too much. Maybe no TikTok names, because I just embarrass myself. So we will stop there. But thanks again. Enjoy the evening, and thanks for coming. And thanks to our speakers, you've been brilliant, absolutely brilliant. Thank you so much.